that you understand this. Whenever there is a granuloma, if it is a tuberculous bacilli onset granuloma, we can see a lot of necrosis. So this necrosis is caused by the nitric oxide, and this necrosis is known as caseation, which is seen in the middle of a granuloma. And this caseating granuloma is a hallmark for the diagnosis of a tuberculosis. So primary tuberculosis, what could be the definition? This is a disease that can develop in a previously unexposed or unsensitized patient. Remember that this is a disease occur in a person who never came in contact with any kind of tuberculosis ever in his life. So naturally most of these patients are not very adult, or most of the patients are very much aged. So what is the timeline? So between 10 to 20 years, between that particular time, the second decade of the life, the patients are basically exposed to this kind of infection. In the countries like Africa and Asia, this patient could be a little bit of younger. Even at the age of 5, 6, 7, 8 years, the patient may be exposed to this kind of infection. And when the patient has a primary tuberculosis, it will produce a classical morphological feature of the lung, which is known as Ghon's complex. So when you suspect a patient with a primary tuberculosis, you look for lung infection, you look for a kidney intestine infection, you look for a cervical lymphadenopathy. So just focus on these three organs: lungs, intestine, lymph node, cervical lymph node, if we suspect a patient with a primary tuberculosis. Now question is that how do you suspect it? You suspect a patient having a primary tuberculosis. First of all, the patient is not very elderly. But some cases in the United States, we can see the elderly patient having the primary tuberculosis. The patient presents with a weight loss, but this is a moderate weight loss. Patient will tell you the patient is having some kind of fever, very mild fever during the evening. Patient will lose appetite, and patient will describe about the night sweat. So these are the three basic points: evening rise of temperature which is very mild, night sweat, and loss of weight. At the same time, some of the patient would complain that he is not feeling to eat, he doesn't feel to eat. Now once you suspect a patient with a primary tuberculosis, you take a X-ray of the chest, and what we see in the X-ray in the chest is known as Ghon's complex. So Ghon's complex is what? It is a combination of two important areas of granuloma. The patient will have a subpleural granuloma in the lungs, and I want you to see this gross picture. This is a nice granuloma, this is a caseating granuloma. So this granuloma looking a little yellow in color, cheesy yellow. So we can appreciate there are 1, 2, 3 granulomatous lesion subpleura just below the pleura. So this is one component of the Ghon complex. What is the next component of the Ghon complex? The next component of the Ghon complex is this lymph node. So whenever there is infection in the subpleural location, infection will travel all the way to the hilar lymph node and produce a granuloma or caseating granuloma in the lymph node. So I just make a small correction over this picture. This lymph node, what we see here, is similar to the lymph node what we see in this portion of the lungs. So this lymph node is equal to the lymph node that we see in the lung X-ray. If you look at the lung X-ray now, we can see multiple lymph nodes. We can actually count it: 1, 2, 3, 4 enlarged lymph nodes, and these lymph nodes are a part of a Ghon's complex. So what is a Ghon complex? It is a combination of subpleural granuloma plus hilar lymphadenopathy. Both of them would show the caseating necrosis, and this is a feature consistent with a which kind of tuberculosis? Yes, you are right, it is known as primary tuberculosis. This is a picture consistent with a biopsy from any kind of caseating granuloma. We can see at the center here in this location, this is a caseating necrosis. We can see the necrotic tissue, little bit of eosinophilic in color. It is little amorphous, granular appearance, and this is a caseation look like. So caseation normally present at the center of a granuloma. So what we see in this area we can see all these blue color cells, tiny blue color cells. They are all actually epithelioid cells, and here we can see a giant cells at the top of it, which looks like a Langhans giant cells. So all these three things together give the diagnosis of a tuberculosis. Let us see it again. These are caseation, pink amorphous material with some necrotic tissue. You can see some blue dots which are degenerated neutrophils or the cells. We can see some epithelioid cell over here. The blue color cells are epithelioid cells, and then we can see that Langhans giant cell. Here I would like to just give you an idea how the epithelioid cell look like. Remember, when you discuss about a macrophage is a large cell like this, and within the macrophage we can get a round nucleus. Now once it becoming epithelioid cell, what happens? The cytoplasm which is present in the macrophage becoming a little bit of more voluminous. At the same time, this particular cytoplasm most of the time you cannot define, you cannot see that. But what we see most of the cases in the epithelioid cell is a elongated nucleus like this. Now this is elongated nucleus. This is a thing we can actually see on the microscopical examination. So whenever we are saying it is epithelioid cell, we are basically looking at the nucleus of the cell. Now coming back to the picture again, we can see all these cells, blue cells. Just look at the tip of the mark pointer. You can see a nice blue cells elongated. This is basically nucleus, and that is how the epithelioid cell look like. And many epithelioid cells together produce a disease which is known as granuloma. So what can happen to this primary tuberculosis? Remember, 90% cases this will resolve. How they will resolve? Simply this will go away. And some of the cases what happens, this granulomatous area both in the lungs and in the lymph node, they become calcified and we get a dystrophic calcification. So we can call this is what is the fate of the most primary tuberculosis, that it can produce a calcification, and that is a dystrophic calcification. Interesting thing is that many cases of the patient who has the primary tuberculosis or who had the primary tuberculosis, this calcification we can identify if we take a X-ray chest of these patients. Few patients actually progress to the progressive primary tuberculosis, which is a very dangerous disease, typically in those patients who has a severe immunodeficiency. Some cases what happens, some of the bacilli, they harbor in the apex of the lung for survival. They don't die. This is not many cases. Remember, when they try to survive, when these bacilli they want to survive, they go towards the apex of the lung, because it is the apex of the lung where there is a high oxygen level.